have the pleasure of talking about healthcare in 2013. 2013 is going to be a big year for healthcare. There's an enormous amount of exciting research, both in mobile health and in personalized medicine. At the same time, the Affordable Care Act is continuing its torturous implementation, with 2014 as the big year when Medicaid will be expanded, when people will be required to get insurance, and this continuing question of how you expand access to health care, how you improve health care, how you lower costs is going to heat up in the next year, if that's even possible, given the tenor of the debate in the past few years. But to discuss these issues, we have Esther Dyson, the chairman of EDventure Holdings and an angel investor. She also has trained as an astronaut, and it turns out that going to space is much, much easier than health reform. So first, please welcome Esther.
Good morning. So I'm going to talk very briefly, make predictions for 3 markets concerning health. They are the markets for healthcare, which you're all familiar with, the market for bad health, which you're also familiar with, but maybe not under that name, and then finally, the market for health itself. So the healthcare market is what you think of: drugs, pharma, insurance companies, doctors, hospitals. In the US, we've now got, in quotes, health reform, and things are changing, but they're going to change slowly. Incentives are slowly turning towards keeping people healthy rather than treating them when they're sick. The drug companies are going to continue to whine because they can't charge enough for their drugs, and that's why they can't make new drugs. The insurance companies are going to whine because they have to treat people that are sick as opposed to just the healthy ones that they pick. But they're going to figure out, to some extent, how to align their incentives with that. The government is going to not pay if you have to readmit somebody. So companies like HealthLoop, in which I'm an investor, are helping institutions to change their processes to improve that kind of thing. And that will continue. I think overall it's pretty good, but don't expect any dramatic changes. The market for bad health. Companies are beginning to understand that they need to promote healthy food. So they're going to put new additives into the same old bad food. So now you have like fruit bars with yogurt, or you have candy with fiber. Watch out, more of that. It's really, really hard because there's a huge market for bad food. It includes not just the bad food itself, but advertising. Everyone around you is eating stuff that's full of sugar and salt, and it tastes really great. So that will continue as well. The third market, for good health, we're seeing some exciting and dramatic changes based on 2 fundamental things that have been moving along for a while, but are coming together. And you're going to see announcements even over the next few days, as well as in 2013. It's, first of all, the rise of user-generated data, whether it's things like my Nike Fuel or my Fitbit that let me count how many steps I've done, all kinds of iPad and iPhone apps that let you monitor your sleep, your blood pressure. The big holy grail, which may or may not get closer to being realized in 2013, is a non-invasive monitor for internal biomarkers like blood sugar and various other chemical components in your blood. There's a big excitement now about the bacteria in your gut. People are going to start collecting that stuff on themselves, sharing it, posting it, et cetera. And so the second half of what's making this all happen is online networks. You heard about social media. This is social health data. It will be used in 2 ways. One, people will encourage other people through gamification to engage in healthy behavior, avoid the products of the second market I mentioned, or at least eat them in moderation. And then also, we're going to be generating a whole lot of data so that we can do what amounts to phase 4 clinical trials out in the open after drugs are released, or maybe things that aren't cost effective because nobody's excited about selling them, like oat bran, or the number of glasses of water you drink, or sleeping more. We're going to generate data that will allow us to quantify the effects of our behavior on our health.
Thank you. Thank you. I think your last point is a very good segue for our next speaker, Daniel Kraft, who's the executive director of FutureMed and thinks a lot about very fast developing technologies in medicine and healthcare generally. Please welcome Daniel.
Great. So it's a fast-moving world, and I think the world in 2013 needs to shift. I can have my first slide up, please, from where it's been currently. So I recently was back at Massachusetts General Hospital where I did my residency in the 90s, and if you go to any hospital day or clinic, it's often sort of as it's looked for the last 100 years, sort of defined in old buckets. I visited my old ward. Not that much had changed. I think the opportunity in 2013 is to start unsiloing healthcare, getting out of sort of the buckets that we've defined ourselves in terms of anatomy and ologies, and start crowdsourcing and thinking differently. And part of that big shift with Obamacare and beyond is to take the incentives. Today, as physicians, we practice not evidence-based medicine, but reimbursement-based medicine, shifting that curve to the left. And technologies are enabling us to watch our health and shift that curve to some degree. There's also pressure now to take healthcare out of the hospital and the ICU increasingly into our home and onto our own bodies. I'll show you some examples of that. A lot of that's been enabled through a lot of really, really fast-moving technologies. We're sort of in an exponential age now. And what's interesting, you know Moore's law, but there's other disruptive, fast-moving technologies, not just computing, and they're coming together and helping a variety of folks reinvent healthcare in a variety of ways. So in genomics, we've now dropped the price of sequencing a human genome at twice the rate of Moore's law. I think Esther was the third person on the planet to be sequenced. This year, there were a few thousand. In 2013, there'll be tens of thousands of folks sequenced, and we're going to start to learn what to do with some of that data as we put it together. Huge opportunity and challenges. It's not just sequencing, it's our proteome, the fact that you can now drop something in the mail and get your gut biome sequenced and analyzed. All that will come together and provide this sort of new big data era. Computation is getting faster, there's sort of faster computing. So one prediction will be that we're going to change old procedures, such as the old angiogram, and start essentially doing those with quick CT scans done in the cloud. So for example, HeartFlow is now doing a 30-second CT scan, sends it up to the computers in the cloud. You can analyze the coronary blood vessel and then personalize the therapy for that individual. Do they need a stent or not? If so, what kind of stent? And so that convergence of cloud, big data, and better imaging is going to come together in powerful new ways, including how, for example, we might replace ultrasounds with quick MRIs that you can access on the fly from your mobile laptop. Obviously, the phone has been a dramatic change in its evolution, and it's being very impactful in healthcare. In 2013, we're already in the sort of iPad era, but now, just in the last few months, there's been a $35 Android tablet being produced in India. So this has huge implications for both healthcare, education. We'll start to give these away to our patients, and essentially, we're going to start to see these new dashboards on our mobile phones, on our cheap pads. The fact that we can get, I think, a prediction is we'll be prescribing apps in the next year as physicians. That's being mixed, as Esther mentioned, with gamification to keep people engaged. We're seeing the digitization of data, not just through our regular phones, but increasingly their ability to use them as smart platforms. So just actually last week was this new iPhone case, which is approved, that can enable me to do a real-time EKG on my phone, send it to my cardiologist, or it could be used for a triage nurse. So that's an example. You can see how I'm heart 104. That's one example of something moving to the phone. And it's not just diagnostics. It's my Basis watch, which will come out next year, that can measure my heart rate and my motion. Scales that tweet have been out, but they're getting smaller. We have sensors everywhere, and those are becoming to the point where we can have point-of-care diagnostics. And the idea of a checkup wherever you might be, telemedicine, the fact that you can visit your physician now on your smartphone is going to evolve quickly in 2013. To the point where we have devices in our bodies, and who owns that data is becoming a challenge as well. Finally, artificial intelligence is going to become more common stream in healthcare, because we can't keep up. We need intelligence augmentation if we're to understand as clinicians what's happening with our patients and to integrate all this new data, to the point where we almost will have sort of an OnStar for our bodies with sort of sensors everywhere. We're starting to wear simple versions of those, and those are getting more complex. Just last year, there was a Tricorder X Prize announced, and we have versions of tricorders today, a $10 million purse. 100 or 200 teams have entered that competition. Here's an early prototype of one that was just released, or not just announced today. I don't know if I can do the quick demo, but the fact now that I can put this little tricorder device on my forehead and get streaming data to my smartphone, which you can sort of see here live, temperature, heart rate, respiratory rate, pulse oximetry, speaking to my phone and eventually to my clinician will be very powerful. And these will be selling, I think, by the end of 2013. That's the data you just saw. Last couple of examples will be connected health, social media, social connectivity, leveraging our behavior. So what will look like if we stay in health? I downloaded an app the other day. As if we go the wrong direction. This is me if I gain 50 pounds, so I'm leveraged, right?
Oh my God.
So augmented reality in 2013 is going to start entering healthcare. Robotics are starting to move from the severely disabled, enabling the paralyzed to walk, to brain-computer interface to allow the truly disabled to move robotics. But brain-computer interfaces for less than $100 are emerging now that will allow us to control our environments as well as treat ADHD. So for example, here's an app I tried where you can focus your attention and learn where you're focused, so no more Ritalin for some kids. Another prediction is that the stem cell world, and the Nobel Prize came out this year for the person who invented induced pluripotent stem cells, is going to merge with other technologies like 3D printing, which is moving very, very quickly. It's been covered by The Economist. We're starting in the early age of printing organs. In the first few this last year, we'll see more of that with more complex organs in the year ahead. I teach at Singularity University and chair the medicine track there. We're reinventing other elements. I think we're going to see UAVs used to deliver drugs and vaccines in the developing world. We're bringing new people into healthcare who have traditionally not been in healthcare. So for example, at FutureMed, we bring folks together from different spheres. And that's what's really powerful. There's now new programs, folks like designers coming together in healthcare to think how to do things differently. So in 2013, we're going to see design thinking more applicably, just like in the world of aviation. And I've been a pilot and a flight surgeon for the last decade. We're taking lessons and applying them to healthcare. For example, you're familiar with checklists in aviation. Increasingly, they're being put into the operating room and beyond, and those are now being appified. We're starting to see the application of now dashboards. So all this data, simulation. Just like your pilot on the airline, simulation is becoming the norm in medical schools. So it's going to be C1, Sim1, Sim1, not C1, D1, Teach 1, and increasingly changing how we do healthcare. Heads-up displays. The data is now glassified. Just like the heads-up display we have for our fighter pilots, we'll have that for our own healthcare kind of GPS coaches. We want just the right amount of information, not too much information. We'll be overwhelmed. And one thing that's going to impact that is the world of Google Glass. Google Glass is going to come out next year, and we're going to see that applied into healthcare in a variety of ways. So I can see my patients in different ways. I can utilize heads-up display data. That's going to be a particularly interesting tool in healthcare coming ahead, whether that you're trying to lose weight and see your breakfast in a new form as well. Last example will be the example of radar. In this new world of sort of hopefully crowdsourced information-based science, if we can see, for example, our cars, when we drive, our self-driving apps will enable us to crowdsource, for example, the map of Rome. What if we can use healthcare data, unsilo it, and understand where the roadblocks are, where the police are hanging out, the best route to work? That's the opportunity through big data and big analytics when it's put together in smart ways, for example, to know where the influenza is, porting that to your own personal app and understanding what to do with that, leveraging your social network again to know who not to shake hands with that day based on all that integrated. So dashboards are coming into our healthcare. And we're going to starting to move, using some of these new tools from an area that's very episodic and reactive to one that's continuous and proactive. And that can make a huge difference. Instead of practicing stage 3 and stage 4 medicine, we'll pick things up earlier. I think that's, for example, in my world of oncology, we can start to be data donors, not just organ donors. We'll enter this, we're starting to be the world of personalized oncology, where every tumor is sequenced, for example. And pulling all these things together, convergent, fast-moving technologies, I think will help us sort of reinvent healthcare in 2013, because in many ways the future's already here, just not evenly distributed. So thanks a lot.
Thank you for that presentation. It's a really exciting vision that you paint for 2013. The reality of the healthcare sector is often somewhat different. It's not maybe as fast moving as some others. You look at labor productivity, generally across the economy, it's increased by almost 2 percentage points a year. In healthcare, it continues to decline by about 0.6% each year. And there's data showing that electronic health records, which are supposed to boost productivity, actually in many cases raise costs, lower productivity. So there's a gap between the vision and the reality. And what is keeping some of the ideas that both of you have described from taking hold of the healthcare sector in a bigger way?
I will answer that, but I first want to argue a little bit about the productivity in terms of we're not measuring productivity the right way. And that's part of the problem. Imagine, we're measuring, well, how many CAT scans did you do versus how many lives did you improve? And that sounds very airy-fairy, but that's the real problem. The incentives are going in the wrong direction. And we can measure the productivity of what we're counting, but we're counting the wrong stuff. That's what, in part, Obamacare, accountable care, all these other things are trying to change.
It was labor productivity, just to be clear. Yeah.
Okay, but labor productivity, an output of a CAT scan, $20 versus, if you made the CAT scan cost more, you would increase the productivity. And so it's obvious we're measuring the wrong things. We're starting to change that, number one. Number two, we're measuring them too closely. In other words, we're looking for instant gratification. And what you spend now on a home health care aide who looks very unproductive. She makes $12 an hour. She goes and visits old people. She doesn't seem to do much. But those old people are happier, they live longer and healthier, they don't go into the hospital, but they don't go into the hospital next year. So those things don't get counted. There's a huge amount of productivity to be gained, not by paying doctors more, but by bringing in more low-paid people who will make the people they serve healthier.
We can descale. We can now, since we have actually a massive primary care physician shortage, and now with Obamacare, 40 million uncovered Americans will be covered, there's not enough primary care doctors. So using some smart connected devices can give a nurse practitioner the experience and connectivity and background of maybe a whole panel of board certified docs. And you can start to measure that. So at Packard Children's at Stanford, where I did my hematology oncology fellowship, but when we put in an electronic medical record, which is a little kludgy, the UI wasn't beautiful, by the next year, the overall hospital mortality went down by about 20%. So that might have been 30 kids' lives saved, for example. And the new medical students, for example, at Stanford get an iPad with their curriculum day one. So the new generation of digital natives is going to be interacting and practicing medicine differently. But often the payers, they want the old-fashioned clinical trial. They want to show that it works. Sometimes the things move so quickly, you can't do the old-fashioned clinical trials. In fact, we'll start to do, patients like me type online patient-engaged trials in real time. So I can mine the entire database and know what Esther needs based on her genetics and 23andMe profile, for example. So some of the incentives are starting to shift, again, for value-based care. If I, as a clinician, can prescribe you an app and a blood pressure cuff, because 1 in 3 Americans has hypertension, but half of those are uncontrolled, that can dramatically lower costs. And big payers like Medicare are starting to recognize that, and they're funding things if they drive better care at lower cost.
Yeah.
So a big piece of this is both using technology to change workflow on the provider side, doctors and nurses operating in a more efficient way to improve care, as you say. It's also about engaging the patient. You pulled out all these gadgets out of your jacket, and I was sort of thinking about your blazer, sort of the Mary Poppins bag of gadgets.
Wait,
continue to have more out of each pocket. But it's a very specific type of consumer who's going to invest in all of these and be interested in using them or not. How applicable is this era of quantified self, complete health measurement for a broader set of consumers?
Let me take that on with 2 stories. One is, Daniel and I are both kind of weird. We're part of the quantified self movement. And we go out and we get a lot of freebies, but we also occasionally even pay for some of this stuff. And more people, oh, that's so much nicer. Now we can.
It's brain control.
So you'll have these leading edge people who do this, and we're going to start and generate some data. But it's clear we're motivated, we're techies, all this. Employers are going to start saying, we give people free coffee, we subsidize their lunches, I don't know, we have daycare, we have a basketball court. Why don't we try this? maybe these tools will make our employees healthier, because employers, it's not just that they offer health care, but they actually benefit from you being healthy. It's not simply avoiding the costs of ill health, but the benefits of happy workers who show up. And so they're going to try gamification. They're going to have teams that play baseball. With luck, they're going to generate data that shows this stuff really works. And then more and more people will do it because it actually is in their interest and social norms will change. Second is Omada Health. It's a sort of combination of online and human. It's counseling for pre-diabetics. One counselor, 10 people, 10 groups of 10 people. The really cool thing is a lot of the people who go through the program not only lose weight, but they want to become counselors. And so we're solving unemployment as well as diabetes.
Daniel.
I think, Esther mentioned the quantified self movement. That's sort of often the data geeks who want to measure every step. And it's starting to move to sort of quantified health. So these are consumer devices for tracking heart rate and motion today, but soon a cardiologist will prescribe one and it can track a heart patient. And the patients are going to be incentivized because they'll have a dashboard. They might have lower insurance premiums if they stay on top of their diet and activity and it knows that you checked into the gym versus McDonald's. We don't want to let healthcare technology, just for technology's sake, get in the way. I think it can start to enable the patient-doctor relationship. You don't want to see your doctor every time you fill out the same number 2 pencil form with the same questions. If you can walk in and see me and already know, uploaded from your phone, your activity, your habits, your problems, I can have a much more focused visit, and then maybe even a telemedicine visit as a follow-up as opposed to taking half day off of work to check something.
So I want everyone to get their questions ready, and we don't have a limited amount of time. So one last question before we take questions from the audience. The question of who owns this data is becoming increasingly important as we talk not just about Fitbits that you can buy at your corner store, but also implanted devices that generate a more complex stream of information about your health conditions. So how do you see that debate evolving? Who should have that data? Why don't patients have it now?
I think you as an individual should own your own data and hopefully, in some cases, decide to share it, hopefully safely and anonymized. My friend Hugo Campos, who I showed there, has an implantable defibrillator, and the company who makes it won't give him his own data. He's been fighting for it. Potentially smart people, gamers, design folks, data folks could come together and start mining that and looking at other patients and making discoveries, just like there's been X prizes for looking at data from a gold mine, $1 million prize, found $1 billion worth of gold. Maybe we can start to mine some of this health data, and I think with HIPAA and all the other challenges of regulatory and reimbursement, if we incentivize the systems, we can hopefully find some of that gold through connectivity.
Short answer is you own your own data, and then you need to decide, do you want to give it to someone to become healthy, or do you want to donate it to science? Just in passing, there was a congressman talking about genetics data, which in some states, and certainly in many countries, individuals can't get access to. This guy said, women are finding this data and they're taking out their own ovaries, which is completely ridiculous. But the point is, there's still a paternalism both in the medical profession and in the Congress that thinks that we can't handle this stuff.
Questions from the audience?
Hi, I have a question. This sounds all great, all new and cool, but if we don't even have essential health benefits covering hearing aids, and we have a population that's aging and living longer, what's the reality of actually covering any of this? And do you have any thoughts on how to get hearing aids covered?
Great question. Who pays?
I don't know the details about hearing aids, but everything we're talking about is actually going to cost less and bring more health in the long run so that we can afford hearing aids for everybody. I know that sounds like a congressperson speaking.
I'm the person right now lobbying on the Hill for hearing aids, and they're not willing to cover it, and I have been said we have 19 organizations and we can't get hearing aids covered,
Well, so,
which sounds crazy
Yeah.
with an aging population.
Yeah.
Let us come talk to them for you, seriously, because, yeah. With hearing aids, they'll be much healthier and they will cost less. That's your best
this
argument.
question of how you get to, even though there's a long-term savings, there is a short-term cost. So Daniel, do you have any thoughts on how to change the reimbursement?
Well, the payers, the big ones, are starting to pay attention to this, and even, there's thousands of apps out there, too many, but companies like Aetna, to their credit, are buying app companies, putting them together. They realize if you start letting people stay connected and use simple apps for this or that, You can stay on top of some prevention and other elements. And they're recognizing tools that are getting cheaper. Hearing aids, brain computer interface, even for vision is coming, sort of the equivalent for blind. The trick is who pays for it. But hopefully some of these technologies are getting cheaper, like these cheap tablets that can augment those sorts of rising costs in some buckets.
Further questions? There's one.
Okay. I'm in emergency medicine, and I do agree with Ms. Dyson that I think the wrong factors are being measured right now, because what I see where we're measuring like CT use and so forth on physicians or practitioners and grading them and so forth, I've seen children get missed for vascular tumors in their head because people are stopping their use of certain technology. I've also seen Medicare multiple sclerosis patients in tears because they're admitted within 30 days and the new Obamacare, Medicare rulings don't allow readmissions in 30 days. And what isn't measured and is the redundancy in medicine that people, I think, don't see most of the time is that when I take a patient from an outside practitioner for, quote, an admission to the hospital, they've already decided that the patient's going to be admitted. They send them through the emergency room to be admitted again through us to the hospital. That costs extra money. And the other redundancy that occurs, they don't send them in with their studies that they've already done in their lab work.
So what is the question? We have limited
well,
time.
What I'm saying is I think that we aren't measuring the right factors. And I do think that we're going to have to look at other factors in the future to measure that are the redundancy in medicine. And I'd welcome either party.
Well, I'd say, you know, there's equivalencies. You're all familiar with like Yelp for rating a restaurant. There's now various sites that can start to rate your clinicians, and they're going to have more transparency. You're going to know what the surgeon's outcome and infection complication rate is. And for the clinician who keeps bouncing people back into the ER, they're going to start getting dinged for that or rewarded for keeping their patients with good blood glucose control and good blood pressure. So it's, again, where the incentive for that physician is to send them bounce back to the ER. That may change in certain systems. And there's no healthcare system in the US. A Kaiser, a VA, a Geisinger are all very different, and different incentives and alignments happen there.
My prediction for 2013 is we're going to have to get better at statistics so that we can understand the difference between the results of a doctor who gets lots of sick patients and the change he made in their health versus someone who got healthy patients and made them worse.
Last question. Yes.
Yes, you said the patient owns the data. That sounds like very interesting metaphysics, but it's not really practical. When the State Department systematically loses hundreds of thousands of classified secret documents, to think that the patient can protect his data is a fantasy.
Yeah, he can't protect it, but he owns it. And so at least we've got this principle. Yeah, the world is imperfect. And the reality is I leave a piece of hair behind and somebody can get my genetic profile. But the fundamental, just like what Willie Maesterly was saying about democracy, the basic principle is we own it, we should be able to control it, and obviously we want it used wisely, and the world's imperfect.
And there's huge challenges. You've seen the movie Gattaca. What happens now when we're all sequenced at birth? Or what happens when my pacemaker gets hacked and someone says, Daniel, go to the bank machine, take out $400, I'm turning off your pacemaker. But that shouldn't stop us from leveraging and owning that data. Just need to be...
Hand me one of those devices.
Just need to be mindful of it, as we go. So there's balances.
So we have visions of hope and disaster for 2013. Thank you to both of our panelists for speaking with us. Thank you.